This program is brought to you by Stanford University. Please visit us at stanford.edu.
Okay, so anyway, good morning, everybody. Justin, who's very sick and tired, and I'll forgive him if he falls asleep, asked me to give sort of a basic introductory lecture. And so the topic that I chose for today is imaging of the myelopathic patient. Now, of course, there's, countless causes of myelopathy, and we're not going to cover all of them, but we're going to cover some of them that are common and moderately interesting, and others that are less common and more interesting. So what I just want to remind everybody, especially the more junior residents, is that myelopathy is just a general term denoting a functional disturbance and or pathologic change in the spinal cord. So for example, when you're ordering studies, if you have a patient who has myelopathy, the lumbar region may not be the first place you want to start. And we see that not infrequently, where we end up with an L-spine on a patient and really what you wanted was C or T. So just keep in mind, the good communication and making sure that we know where to look in your patient. There are numerous sensory and motor manifestations, which you all will talk about a lot more in your rounds in residency, including weakness, paresthesias, hyperreflexia, bowel and bladder dysfunction, muscle wasting. And so from our point of view, what we're trying to figure out is where all of these things are coming from. With regard to the classification of myelopathy, you're often thinking, clinically, does this patient have a transverse lesion? Is it a central cord syndrome, maybe in somebody who's had a motor vehicle accident? Is it a hemicord syndrome? But from our point of view, on the imaging end, and your point of view, once you start evaluating the images, you're trying to figure out if the patient's problem is located extradurally, but maybe pushing on the spinal cord, intradurally, but outside of the spinal cord proper, or within the spinal cord. And so with regard to that, just on these, old diagrams from an old myelography textbook, you can imagine, of course, that an intramedullary process may expand the spinal cord, but a process which is outside of the spinal cord is going to displace it. If it is extradural, not only will it displace the spinal cord, but it will also displace the subarachnoid space and the dura and expand the extradural space. Whereas if you have a process which is inside the dura, but outside of the spinal cord, you're going to deviate the cord, but instead you're going to have widening of the subarachnoid space and a so-called subarachnoid cap. And as we go through, we're going to be looking at examples of all of these things. With regard to imaging modalities, certainly you'll sometimes get plain radiographs in patients who have had trauma or when you have concerns about stability. We do CT, plain CT, to assess bony structures or calcification. Nowadays, there are still indications for myelography and CT myelography when we want to assess the subarachnoid space or evaluate obstruction to CSF flow, and I'll show you examples of this, certainly in the postoperative state or in patients who can't undergo an MR. But most of the time when you have a myelopathic patient, the way we want to assess that patient is MR. It's our study of choice because of its multiplanar capabilities, its soft tissue contrast, its ability for us to characterize processes, even subtle processes, that involve the spinal cord parenchyma. And so you're going to see that most of what I'm going to show you is MR during this lecture. So let's start off going through our anatomic classification and thinking about the different pathological processes that occur in these different compartments. With regard to extradural causes of myelopathy, certainly degenerative disease is the largest category. We can have anomalies and pathology at the craniovertebral junction, neoplasms of the spinal column and epidural space. Now, trauma is a big category, but that's one thing that I'm specifically not going to talk about today because a few superficial comments about trauma is not really helpful. If you want more on spine trauma, we can do another talk, or Dr. Lane has a lecture on that. Infection, discitis osteo, we see quite a number of cases of that here, and then a whole host of miscellaneous entities, some of which we may discuss. So with regard to cervical spondylosis, overall, this is the most common cause of cervical cord and, of course, root dysfunction in older patients. And 55 may be too high a bar because I think I'm already getting a little bit of neck pain. There are multiple levels affected in most patients. Most commonly, it's C5-6 and C6-7, but certainly it can occur at any level in the cervical canal. Young and middle-aged patients tend to have soft disc, which is often brighter on T2 weighted images, whereas older patients often have calcified discs and osteophytes and may potentially be more difficult to treat. There are a number of predisposing factors, including repeated occupational trauma, congenital anomalies, but most of the time it's a little hard for the patient to figure out exactly why it happened. But here's some fairly typical imaging. This is a sagittal T1 weighted image. You know it's T1 because CSF is dark and fat is bright. You can see that this patient has straightening of their cervical spine. They've lost their normal lordosis, and you can see that at multiple levels. There's osteophyte formation, there's disc bulging. On the T2 weighted images, we see that as well. And not only that, but we also see a focus of high signal intensity within the spinal cord. Now, when you have a cord that's pinched like that and the cord can't be allowed to expand, you don't necessarily know if that focus of T2 abnormality is edema or myelomalacia. But the chronicity of the patient's symptoms, whether there was any recent trauma, you may have to resort to other methods of figuring that out. And when we look at our axial gradient echo images, you can see this disc osteophyte complex. You see the marked narrowing of the spinal canal, the narrowing of the neural foramina, and this is a fairly typical, somewhat advanced case of cervical spondylosis in a middle-aged patient. Now here's a younger man who's already had a cervical fusion, and I don't remember why he had discs at such an early age. Maybe he had trauma or who knows what, or he was a trapeze artist or something. But here on the sagittal T2 weighted image, you see that his spine is straight. He's got this fusion that looks very nice. His cord looks good. But then 5 years later, he develops new symptoms. And now you can see that at C3-4 and C4-5, he's extruded these big pieces of soft disc. And again, once you have a patient who has a fusion and you alter the normal biomechanics, it's not at all uncommon when they get new symptoms that they have actually extruded a disc either above or below the level of your surgery. And so it's important to go ahead and re-image these patients. And here you see these axial images through those two levels where now we have this extruded soft disc, the cord is markedly compressed, and this is a patient with new disc herniations above the level of his fusion. Now here's an older gentleman who has a calcified thoracic disc who's had chronic pain for years, but now he's becoming increasingly myelopathic. On the sagittal reconstruction of the multi-detector CT scan, you see how he has narrowing, and calcification at this upper thoracic level. And he's got this really large calcified disc, which is very dark on the T2 weighted image. You can see that it's pushing on the spinal cord. The spinal cord overall looks somewhat atrophic, but there's also high signal intensity within it, probably representing edema given his new symptoms. But again, it can be hard to sort out if you're looking at irreversible myelomalacic changes or potentially reversible edematous changes. And one other small point to make just about this appearance is that sometimes it can be hard to distinguish a calcified disc from a calcified meningioma. And so, we give GAD, we do other things to try to figure that out. And in this case, where it looks like this is clearly mushrooming from the disc space, it probably is a calcified disc. But I've been fooled before, and probably some of you in the audience have been too. Now here's an older woman who had a low-speed MVA 2 days earlier, and now she has some new mild myelopathic changes, and there's concern for a cord contusion. We look at her sagittal T1 weighted image with dark CSF and bright fat. We see that she's lost her lordosis. In her lower cervical region, she has disc osteophyte complexes. She looks rather stenotic down there. When we look at her T2 weighted image, you can see that her cord, in fact, does have high signal intensity within it suggesting that she probably has contused her cord. Maybe she's, compressed a vein. Maybe she has some venous ischemia. It's also possible that she has arterial ischemia, but her symptoms were relatively mild. And if she had an arterial cord infarct, she would have been much more affected. Now, when we have a patient with trauma, we also generally do a sequence called STIR that most of the senior residents are probably familiar with. But for the junior residents, STIR is a convenient way of doing heavily T2-weighted images with very good fat suppression. So now you can see that we've saturated the fat within the vertebral bodies. We really don't appreciate any abnormality of the vertebral bodies, but you can see that the patient does in fact have prevertebral fluid, consistent probably with a mild ligamentous injury. I don't directly visualize the ligamentous disruption. Sometimes we actually can. But in this case, you can imagine that the patient probably had some kind of hyperextension injury in her MVA. She has some prevertebral edema, and back here at the level where she has underlying spinal stenosis, she has contused her spinal cord. Let's move on to another entity, which is not common, but here we seem to see at least a couple of cases of it every year. And this is ossification of the posterior longitudinal ligament, more conveniently referred to as OPLL. This is a disorder of unknown etiology, which seems to be associated with collagen gene polymorphisms. And it usually involves the cervical level, but it can involve the thoracic level. Much more common in Japanese populations, but we do see it in the US. In non-Japanese populations, much less commonly. And 4 types have been described. There's the so-called continuous type, which goes over multiple levels in continuity. Segmental, where it occurs behind the vertebral bodies. Mixed, where you have a combination of those two, and circumscribed, which occurs at the disc level. And frankly, how they separate that from, disc and osteophyte and everything, I'm not sure. I don't think I've ever called circumscribed OPLL before. So if I do, you should probably, shake me or call me on it or something. It often coexists with ossification of the ligamentum flavum and also with DISH, so-called diffuse idiopathic skeletal hyperostosis. So if you have a patient with ossified ligamentum flavum or DISH, you may want to take a look and make sure that they don't also have a component of OPLL. What does this look like? Well, let's look at a case from a year or two ago of an elderly Chinese male who presented with progressive difficulty walking. This is his lateral C-spine film. You can see he has these large ventral flowing osteophytes consistent with DISH. But in addition, on his plain film, he has this ossified bar posterior to the vertebral bodies. And I think when his C-spine plain film was initially looked at, that was just sort of not really noticed. When he subsequently underwent an MR scan, you can see on the sagittal T2, sagittal T1, and axial gradient echoes that he has this thick band of ossified posterior longitudinal ligament. He has spinal stenosis, which is so severe that it's scary. And when you look at his spinal cord, you can see that in multiple places, not only is it thinned, but he also has areas of T2 hyperintensity that, given the chronic nature and progressive nature of his condition, presumably represent myelomalacia. Here's another patient who presented with dysphagia and also some difficulty walking. And this patient has not only OPLL with ossification of the posterior longitudinal ligaments, but also diffuse idiopathic skeletal hyperostosis with these ventral flowing osteophytes, and also ossification of the ligamentum flavum. So this is a patient who manifests all 3 of those potential associations with OPLL. Now, the DISH per se isn't that important, except it probably explains why the patient had dysphagia from these large flowing osteophytes compressing the cervical esophagus. With regard to the craniovertebral junction and pathology at this level as a cause of myelopathy, what are we talking about? Well, again, we're talking about the occiput, both the basiocciput and the squamosa, the atlas and the axis, C1 and C2, and the associated ligaments. When you have a problem at the craniovertebral junction, the myelopathy is often associated with lower cranial nerve dysfunction. So if you have a patient who not only has myelopathic symptoms, but does have lower cranial nerve symptoms, that's where you want to be focusing your attention. Now, if you know the patient has a congenital problem, like Down syndrome or achondroplasia, if you're rotating on the Mike Edwards PD service, if you've got a kid with craniofacial syndromes and vertebral anomalies, those children very commonly have severe stenosis at the craniovertebral level. But we also see adults with problems at this level. And why do we see it? Well, in elderly patients, we may be dealing with so-called CVJ pseudotumor or ligamentous thickening that occurs in elderly patients. You may have a patient with rheumatoid arthritis or CPPD, calcium pyrophosphate deposition disease. Patients may have amyloid arthropathy, which often occurs in the context of chronic hemodialysis, or seronegative spondyloarthropathies. And here's just an example of an elderly patient that I saw a few years ago back at UCSF who had known CPPD disease that was affecting his knees and his hips, but he then presented with myelopathy. What do we see? Well, here's a sagittal T1 weighted image with dark fluid, bright fat. You see up at the level of C1-2 that the C1-2 interval looks pretty good. The dens is not whittled. This is not a patient with rheumatoid arthritis, but he's got this large mass of abnormal soft tissue, which is markedly squeezing the upper cervical cord. When we look at our sagittal T2 weighted image with bright CSF, you see that the cord is pinched and hyperintense. When we give gadolinium, there's some mild diffuse enhancement of this process, and when we look at the CT scan, there's some stippled calcification, which is consistent with a diagnosis of CPPD disease. Here's an example of a little girl with Down syndrome who also has progressive myelopathy. What do we see? Well, on the MR, we appreciate the fact that she has severe narrowing at the level of her foramen magnum. You can see that her spinal cord is pinched. She's got T2 hyperintensity, some of which strikes you more as probably chronic myelomalasic changes, and some of which strikes you more as probably cord edema, explaining the fact that she's been progressively myelopathic and is now presenting. But in terms of sorting out this confusing bony anatomy, even though you get a pretty good look at things on the MR, it's often very helpful to do a CT scan. So when you do have a problem at the craniovertebral junction, CT and MR often can be complementary. And in this particular case, what we see is a large os odontoideum shown right here, which is fused to the anterior arch of C1, and both of them are anteriorly displaced. But the CT scan, as you can appreciate, was actually done post-operatively after the patient had had a large multi-level laminectomy and occiput to C5 fusion and was looking quite good, and her symptoms had been significantly improved. Let's move on to some other pathologies of the epidural space, or we won't get through everything. So what about epidural hematomas? Well, I said we weren't going to talk about spine trauma, but you don't necessarily only get spinal epidural hematomas, which, by the way, are usually venous, unlike intracranial epidural hematomas, in the context of a motor vehicle accident. Certainly, they can occur with vertebral column injury, but if you're doing an epidural steroid injection, that can cause a hematoma. Just a regular old lumbar puncture, especially if the patient is somewhat coagulopathic, epidural and spinal anesthesia can do it. So not uncommonly, we get these emergent requests from anesthesia asking us to do MRs on postoperative patients because they're worried about an epidural hematoma. An acute disc herniation is not usually associated with a clinically significant epidural hematoma, but it can be, and you can just get a spontaneous one if the patient is coagulopathic, has a vascular malformation, or a tumor. And if you're trying to sort out whether the stuff in the epidural space is blood or not, a gradient echo image in the sagittal plane can be useful. And this is just a case that I saw a number of years ago of an 89-year-old gentleman who was status post total hip replacement. And he had an epidural catheter in place for post-op pain relief, and then he was unable to move his legs, and even at the point where they were lightening up and he should have been able to move his legs, he was unable to move his legs. So he was brought down to the MR scanner, and what do we see? Well, his vertebral column actually looks pretty good, except for some old injuries, but here's his spinal cord in the upper thoracic region. Here's his nice subarachnoid space, and then all of a sudden we see this dark line. What is that dark line? Okay, that's the dura. Okay, so on MR, we can see the dura. So the dura is being displaced by this large multiloculated collection, which is severely compressing this elderly gentleman's spinal cord. You can see that this heterogeneous epidural hematoma extends all the way down his thoracic levels and into the upper lumbar region, where, by the way, he also has horrendous multi-level spinal stenosis, and this patient required a large multi-level laminectomy to evacuate that epidural hematoma. What about neoplasms? Well, I'm not going to say too much here because during the course of your residency, you're going to see one of these a week probably when you're on whatever service it is that admits these patients. So neoplasms of the spinal column and epidural space can either cause spinal cord compression directly when they're very large, or when they're complicated by vertebral body collapse and pathological fracture and retropulsion of blood, bone, tumor, whatever else. Metastatic disease complicated by cord compression occurs in about 5% of cancer patients, and given our large cancer population here, we see it quite frequently. We also see it in the context of lymphoma and myeloma, and we do see it with primary bone tumors of the spine. Some of you recently may have seen that older woman who had a large chordoma that presented with thoracic cord compression. But primary bone tumors represent less than 5% of all bone neoplasms, so it's much more commonly in the setting of these other entities. But again, if you're on the PD service where more primary bone tumors occur than in adult patients, you certainly will see it. And here was just a 40-year-old patient who turned out to have a solitary plasmacytoma. You can see on the sagittal T2 weighted image, we have this intermediate signal intensity soft tissue mass, which is destroying multiple contiguous vertebra. There's retropulsion of tumor and bone. The cord is severely compressed, and post-gadolinium, this process enhances intensely and homogeneously. Is this scan diagnostic of a plasmacytoma? No, this could be a primary bone tumor, this could be metastatic disease, it could be lymphoma. It's hard to make it something non-neoplastic, but clearly this patient is going to need tissue sampling in order to make an appropriate diagnosis. Now, what about infection? We do see a lot of discitis osteomyelitis here. You know how these patients present, so I'm not going to go into it. They often have neurologic deficits, either because of direct compression of the cord, because of bony collapse, bony retropulsion, or epidural abscess, or they can develop retrograde thrombophlebitis of spinal epidural veins. Remember that discitis osteomyelitis caused by typical pyogenic organisms is usually centered at the disc level, but multiple levels can be involved. So it's not a bad idea if you have a patient with, say, cervical discitis osteomyelitis, and you're looking at the cervical canal, to also get a quick sagittal look at the thoracic and lumbar levels, because your patient may have multi-level disease. Now, epidural abscesses can occur in the absence of discitis osteomyelitis, but that's a lot less common. But we do see it with diabetes, IV drug abuse, and in the context of HIV. And here's just a fairly typical but pretty far advanced sagittal CT scan looking at the cervical spinal column in a patient with discitis osteomyelitis, where you can see that the problem is centered at the disc level, the vertebral bodies are fragmented and collapsed, and you can imagine that this patient might be suffering or having myelopathic symptoms from lower cervical, upper thoracic cord compression. With regard to MR imaging, I know we're down at the lumbar level and we're below the conus, but this scan particularly well illustrates the typical MR findings of discitis osteomyelitis. On T1 weighted images, we have decreased signal intensity in the vertebral bodies and loss of end plate definition. On T2 weighted images, with typical pyogenic discitis osteomyelitis, we like to see increased signal within the disc space and increased signal within the contiguous vertebral bodies. Post-gadolinium, we have contrast enhancement of the disc space, but sometimes the disc space is so pussed out that you won't get much enhancement, and we have enhancement of the vertebral bodies. And that enhancement may persist for weeks to months, even as the patient is getting better. In this case, you can also see that the patient has ventral phlegmon, which is elevating the anterior longitudinal ligament, and also epidural phlegmon, which is causing stenosis of the thecal sac at this level. Here's a patient who presented a couple of years ago. I think this was actually Dr. Shore's patient, and he was a healthy middle-aged man who complained of neck pain. And he had an outside scan with no gadolinium, and they sent him in here, and we rescanned him. What do we see? Well, here's a sagittal T2 weighted image. He's got some mild cervical spondylosis, but the vertebral bodies look good. But what's this black line? That's the dura. The dura is being elevated by something, and the patient's cord is very mildly compressed. Sagittal T1 weighted image, we see this abnormal intermediate signal intensity material within the dorsal epidural space. And post-gadolinium, we have this long segment, fairly homogeneous enhancement, but there's one little focal area of non-enhancement. Could this be something infiltrative, like lymphoma in the epidural space? Yeah, but that little focal area of non-enhancement would be a little bit odd. And it turned out that the patient hadn't been feeling well for a few weeks. He had some low-grade fevers, and this turned out to be cervical epidural abscess and phlegmon. He had no discitis, and the etiology remained unclear. If the disc space is relatively uninvolved compared with the vertebral body, you need to think about atypical organisms like TB and fungus. And here we have a 15-year-old girl who presented with progressive neck pain as well as intermittent fever and night sweats. Now, her initial lateral film of her C-spine, the bones looked funny, but it was hard to tell what was going on. But she had massive thickening of her prevertebral soft tissues. When we look at a CT scan, again, we see this major soft tissue abnormality of the prevertebral space, as well as fragmentation and collapse of a mid-cervical vertebral body. But again, the disc space doesn't look so bad. And when we look at the sagittal T2, that confirms our impression that the disc spaces are in fact normal, but the vertebral body is markedly abnormal, it's collapsed, and there's this multiloculated collection which is elevating the anterior longitudinal ligament. And this turned out to be a case of Coxy involving the spine with this large prevertebral abnormality. Okay, now that everybody has mastered extradural or epidural causes of myelopathy, let's move on to our next compartment and let's review intradural but extramedullary causes of myelopathy. Again, there are large lists, but of this large list, there are only a few entities which are relatively common, and these include nerve sheath tumors, meningiomas, and leptomeningeal metastases. If you're on the pediatric service, you may see patients with dermoids and epidermoids, lipomas. They sometimes present in the adult population. Things like neuroenteric cysts, more common in the pediatric population. Arachnoid cysts can present at any age. Not so much here in California, but if you go to the third world and spend some time, you may see parasitic cysts. Certainly, we do see tuberculosis and Coxy Meningitis with some frequency. Very uncommonly do we see subdural empyema. And then there are some weird miscellaneous causes, which I'm going to show you some examples of. With regard to the common neoplasms, nerve sheath tumors make up about 15 to 30% of intraspinal masses. And here's an example of an elderly gentleman who presented with back pain and lower extremity weakness. He had a history of 2 different cancers, prostate and colon, so we were all figuring that he was going to have metastatic disease and cord compression on that basis. But what do we see? Here's a sagittal T1 weighted image. His vertebral column looks absolutely normal, but we see this ovoid mass which is severely compressing his lower thoracic cord. When we look at our T2 weighted image, here we see this well-circumscribed, somewhat heterogeneous mass. The cord is severely compressed, but in this case, I don't see a black line of the dura being pushed away. Instead, what I see is the subarachnoid space being widened at the superior and inferior aspect of the mass. That is the so-called subarachnoid cap, which is diagnostic of an intradural but extramedullary lesion. Post-gadolinium, you can see some moderate, fairly intense, fairly homogeneous enhancement of this lesion, and at the time of surgery, this in fact turned out to be a schwannoma. Meningiomas are also pretty common. Mostly we see them with older women. Mostly they occur at the thoracic level. So here's an example of an older gentleman who presented with slowly progressive myelopathy. In this particular case, we again see a lesion which has a base on the dura. You can see that subarachnoid cap as the cord is pushed away and the subarachnoid space is widened above and below the lesion. It's intermediate on T1, on T2. It's intermediate on T1. It enhances intensely and homogeneously post-GAD. Here you can see how it's really severely squishing the upper thoracic cord. Oops, sorry, and I didn't have a little thing. And this patient has a meningioma. All right, what about those non-neoplastic masses? Well, dermoids and epidermoids are often associated with dermal sinuses. Epidermoids can be associated with prior trauma like lumbar puncture, and dermoids usually have fat signal, but remember that neither one of them should enhance unless they're secondarily inflamed or infected. In the case of lipomas, a percentage of these patients will have other associated spinal anomalies, so it's important to look carefully at the vertebral column. In some cases, lipomas can actually either be intramedullary or they may appear as such because they have a predominantly subpial location. So in this particular case, this is a pre-GAD T1 weighted image. On the pre-GAD, we have this very hyper-intense mass. We have this widening of the subarachnoid space. We have this compression of the spinal cord. When we do a fat saturation pulse, you can see that the signal goes away. So that confirms the fatty nature of this lesion. And when we look at the axial T1 weighted image, we can see how the cord is really being deviated and compressed, but at the time of surgery, this actually was in a subpial location, according to the neurosurgeon who decompressed this lesion. So this is a patient with a spinal lipoma presenting with progressive myelopathy. Again, in that category of non-neoplastic congenital masses, we may see arachnoid cysts, we may see neuroenteric cysts. Neuroenteric cysts are often anterior to the cord and associated with vertebral defects. What about this case? Well, here we have sort of a cigar-shaped T2 hyperintense lesion, which is posterior to the spinal cord. It's causing severe cord compression, and again, you can see that subarachnoid capping with that widening of the subarachnoid space above and below the lesion. This patient had a myelogram. When we look at the myelogram, it looks like this patient has two spinal cords, but in fact, this more anterior structure is the compressed and atrophic spinal cord. This more posterior structure actually filled in with omnipaque at the time of follow-up. Oops. And this patient had a large dorsal thoracic arachnoid cyst and subsequently underwent a laminectomy and decompression of her arachnoid cyst. And she had no history of prior infection or trauma, and it was unclear if this was congenital, or what the problem was with regard to that lesion. With regard to infection, pretty uncommon around here to have parasitic cysts, but certainly, as you all know, we've had a number of patients in recent years who have had TB or Coxy Meningitis. These patients have marked exudation into the subarachnoid space that can be so thick that it can cause compression of the cord. These patients also can develop CSF loculations and focal masses. And here's an example of one of the patients we saw recently with Coxy Meningitis. On the sagittal T1 weighted image, at first glance, it doesn't really look that bad. But what's the problem? Well, the problem here is that you can't really distinguish the spinal cord from the subarachnoid space. Well, maybe it's because the cord is expanded, but maybe it's because there's something in the subarachnoid space, or maybe in this case, it's because of both of those things. So we look at the sagittal T2 weighted image. Now we can appreciate the subarachnoid space that previously we really couldn't appreciate because it's iso-intense to the spinal cord. But in addition, you can see that this patient does have some edema and mild expansion of the lower cervical upper thoracic cord. When we look at our T1 weighted image post-GAD with fat saturation, at first glance, if I hadn't labeled that, most of you probably would have thought that this was a T2 weighted image because the subarachnoid space is so bright. But in fact, that's diffuse gadolinium enhancement of the subarachnoid space in this patient with very severe Coxy meningitis. Now, this is sort of a weird entity that I want you all to be aware of because radiologists often misdiagnose this or don't know what this entity is because it's pretty uncommon. Transdural cord herniation is a rare cause of progressive myelopathy that relates to a focal defect in the dura, which can be traumatic or postoperative, but it's often congenital, and it usually occurs at the T4 to T6 level, either ventrally or ventrolaterally. What do you see? You have a segmental ventral displacement of the spinal cord, as well as focal cord atrophy or distortion. So here's a patient with progressive myelopathy. You can see on the SAGT1, his vertebral column looks normal, but you've got this funny little jog of the cord. We see that much better on the T2 weighted image. On the axial T1 weighted image, it's as if the cord is stuck up there ventrally. And when you look at an axial slice from a myelogram, you can barely even appreciate a little bit of that ventrally herniated spinal cord at this level. Here's another patient with classic findings of a ventral dural defect shown on myelography. Sagittal reconstruction, we see that funky little ventral jog of the spinal cord. Axial images, cord's pretty normal, but it's a little small. The cord is moving forward, the cord pokes out a little defect, and then we come down back to a relatively normal level of the spinal cord. So important to recognize that. Okay? Oh, I'm sorry, I thought I had another slide. Important to recognize that because very often, what do these patients get misdiagnosed as? They get misdiagnosed as dorsal arachnoid cysts. And patients undergo unnecessary laminectomies and explorations where you hear that, well, they opened up the patient and didn't find anything. Well, that's because the pathology is ventral, not dorsal. Okay? So now you're all aware of that. What about superficial siderosis? Superficial siderosis, as many of you or most of you probably know, is caused by widespread deposition of hemosiderin in the leptomeninges and subpial tissues. Most of the time, these patients will present with hearing loss and ataxia, but sometimes they may be myelopathic because of involvement of the meninges overlying the spinal cord. And here's an example of a patient we saw a couple years ago who was actually a stuntman who had had multiple minor repeated traumas over the years, and he was becoming deaf, ataxic, and myelopathic. On his axial gradient echo through the brain, you see the classic features of superficial siderosis, as if somebody has taken a black Sharpie and traced all the surfaces of the brain. But in addition, when you look down at his spinal level, you see how there's a black line all along the surface of the spinal cord. And in addition, this patient's spinal cord is atrophic and mildly T2 hyperintense. Causes, there's numerous causes. Intracranial neoplasms with chronic bleeding, aneurysms and subarachnoid hemorrhages, vascular spinal tumors like ependymomas and paragangliomas, and patients who have had trauma like root avulsions. Because when you have healing in granulation tissue, the tissue is often friable, and repeated minor trauma over the years can cause repeated episodes of bleeding. Okay, last area that we need to conquer, intramedullary causes of myelopathy. Again, there's tons of them, and I'm just going to show you a few examples from these different categories. So let's just move forward. What about neoplasms? Well, with regard to primary spinal cord neoplasms, ependymomas and astrocytomas certainly rule, and certainly when we're in tumor board, that's what we're often trying to sort out. Ependymomas overall are the most common intramedullary cord neoplasm, the most frequent intramedullary glioma in adults. They often have rostral and caudal reactive cysts associated with them, and they are often hemorrhagic. Astrocytomas are the most frequent intramedullary glioma in kids. Fortunately, most of them are low grade, but unfortunately, they're often highly infiltrative. And so therefore, unlike the ependymomas, on which you're often able to get a very nice resection, it's very difficult to get a good resection of cord astrocytomas. So here are two different patients, one of whom has an ependymoma and one of whom has an astrocytoma. Which is which? Well, here we have a sagittal T2 weighted image. We have a very well circumscribed lesion. We have a cap of hemosiderin superior and inferior to the lesion. as well as T2 signal extending away. Now, without a T1 weighted image, you don't know if that's edema or if that's actually a cyst, because they're going to look the same on T2. Here's another patient who's got marked focal expansion of the upper cervical cord, but the margins are very ill-defined and infiltrative. There's no hemosiderin, there's no cyst. This patient is 35, this patient is 7. This is a fairly typical cervical ependymoma, and this is a classic cervical astrocytoma. Spinal cord astrocytomas are often very large. That patient's lesion was relatively small, and they typically brightly enhance, but not always. Here's a young patient, 3 years old, with a cord astrocytoma. You can see this massive multi-level expansion all the way from the lower cervical region down to the conus medullaris. And superiorly, we do in fact see a syrinx and also some presyrinx or cord edema above it. On the post-GAD image, you can see that the cystic part, or the syrinx, is non-enhancing, whereas the tumor is pretty intensely enhancing. Here's another little girl, also with a cord astrocytoma. You can see some cyst formation superior to the tumor, and then down at the level of the heterogeneous tumor, we have this fairly intense gadolinium enhancement. Contrast that with a young man with a cervical ependymoma. Much smaller, much more limited. We have a nodule and a cyst in this case. They can be quite cystic, they can be partly cystic, they can be purely solid. So very variable appearances of cord ependymomas. Here's our focal nodule, here's our cyst. The nodule enhances post-gadolinium, and you can see that on the axial post-GAD image and also on the axial T2 image, where you see cyst adjacent to nodule, cyst adjacent to enhancing nodule. And this is a patient of Dr. Harsh's who I think was operated on earlier this year. Now, metastatic disease, it's strange, but there's actually a pretty low incidence of hematogenous metastases to the cord as compared with the brain. And so relatively rarely do we see mets to the cord, but if we do, they're usually lung and breast cancer, they're usually in the thoracic cord, and they're usually in patients who are already known to have widespread metastatic disease that typically also involves the brain. And here's an example of a patient with a history of metastatic lung cancer, known widely metastatic disease, who presents with upper extremity weakness. And your first thought would probably be that the patient has a bony met and, either foraminal or cord compression. But in this particular case, we see that the cord is fat. So we have an intramedullary lesion. On the T2, you see this intermediate signal intensity, highly cellular lesion with major cord edema extending away from it. Post-GAD, we have fairly homogeneous enhancement in a patient with metastatic lung cancer to the cervical spinal cord. What about hemangioblastoma? Relatively rare, but we do see them. And here's a young man with a cervical hemangioblastoma. The cord is fat and expanded. We see a cyst and a nodule and lots of edema. Why is this not an ependymoma? Well, just on the T2 weighted image, it looks pretty similar to the guy that I just saw you. But ependymomas do not typically have so much cord edema associated with them. I suppose maybe one could, but they don't usually, whereas hemangioblastomas often have a lot of edema. In addition, when you look at the post-GAD image and you see this brightly enhancing nodule, right next to the nodule, can you appreciate this little serpiginous black thing? That's actually a vessel. And very commonly with hemangioblastomas, either in the cerebellum, unless they're tiny little nodules, or in the cord, you'll actually identify an enlarged associated vessel. And when you see that, you can be pretty sure that this is a hemangioblastoma. This particular patient was not known to have von Hippel-Lindau, but when you do diagnose what you think is an isolated hemangioblastoma, it is important to think about that. All right, let's leave neoplasm behind and let's move on to our sort of enormous category of inflammatory or idiopathic entities. And very often, or probably more commonly on the neurology service, but you may see this or they may consult you, you may have a patient who presents with a syndrome of acute transverse myelitis, acute loss of sensory and motor function with a transverse segmental level. And you have to have absence, obviously, of cord compression or some other known neurologic disease. but the rule-out diagnoses when you go to evaluate these patients and work these patients up include things like MS, ADEM, collagen vascular disease, vasculitis, sarcoidosis, viral infection, syphilis, and that's just the list off the top of my head. If we really worked, we could probably come up with hundreds of things. Okay, so with regard to multiple sclerosis, this is the most common cause of spinal cord demyelination. The cord is involved pretty frequently in MS, but fortunately, well not fortunately, but fortunately for us from the imaging point of view, concomitant brain involvement is frequent. And so if you have a patient with a cord lesion where you're wondering about demyelination and maybe multiple sclerosis, it's very helpful to image the patient's brain, because if you see multiple T2 abnormalities in a young patient, that really ups your ante for the diagnosis of multiple sclerosis. What do demyelinating plaques typically look like? Well, they're typically peripheral and dorsolateral. They're usually less than 2 vertebral segments long, less than half the cross-sectional area of the spinal cord, and much less likely to respect gray-white boundaries than our brain plaques. So here's a typical demyelinating lesion in the spinal cord of a patient with known multiple sclerosis. Sagittal T2 weighted image. We have mild expansion of the spinal cord by this sort of flame-shaped lesion, which is less than 2 vertebral segments in length. When we give gadolinium, we have some mild peripheral enhancement. When we look at the axial T2, we can see that this lesion is, well, maybe in this case it's about half the axial diameter of the spinal cord. And when we look at the post-GAD image, we see some mild peripheral enhancement. And you could argue, I mean, this plaque is pretty big, but it's kind of dorsolateral. So really this plaque fits all of these rules, and this was indeed a demyelinating lesion in a patient with multiple sclerosis. What about ADEM? Well, as you all know, this typically follows viral infections or immunizations, and it's far more common in kids than in adults, but we do see it in adult patients. It's classically monophasic. It usually involves the brain and cord, and you all know this clinical stuff. Here's an example of a 7-year-old boy who a month ago was diagnosed with an EBV infection. And then as he was starting to recover from that, he acutely developed the onset of blindness and weakness, and he was brought to the hospital and he had MR scanning of his orbits, his brain, and his spinal cord. What do we see? When we look at his spinal cord, you can see he has this significant expansion of the lower cervical cord. He's also got mild expansion of the upper thoracic cord. He's got long segment T2 abnormalities of the spinal cord, which is quite different from that much more circumscribed plaque that you saw in the patient with multiple sclerosis. When we look at the brain, he's got multiple white matter lesions. When we look at an axial post-GAD image through the orbits, look at his optic nerve on the right. It's diffusely enlarged and enhancing. His optic nerve on the left is also enlarged a little bit and mildly enhancing. And this is a patient with fairly typical, pretty severe ADEM. Now, what about this patient? An older gentleman with lower extremity weakness, lower extremity sensory loss, gait abnormalities, and upper motor neuron signs. He's got a long segment T2 abnormality involving his thoracic cord without much in the way of cord expansion. His vertebral column looks pretty good. He's got a hemangioma, so what? Post-gadolinium, he's got this sort of mild enhancement. This really doesn't look like a neoplasm. It certainly doesn't look like a typical MS plaque. You know, potentially this patient has ADEM, maybe he has a viral myelitis, maybe he has vasculitis. This patient could have, maybe he has cord ischemia, although his presentation was sort of gradually progressive and wasn't really felt to be consistent with cord ischemia. And this is a case that some of you may remember from a couple of years ago in this gentleman who was eventually diagnosed with CSF PCR as having a very unusual case of measles myelitis. So it's not so much the point of the diagnosis, but just to understand that this kind of appearance could in fact be seen with a viral myelitis as well as something post or para-infectious or potentially with vasculitis involving the cord. What about HIV? Well, back during the time of my training, we used to see patients with HIV who had brain and cord abnormalities all the time. But now that the drugs to treat HIV have gotten so good, it's actually pretty uncommon to see these entities. Now, certainly toxo and lymphoma can involve the cord, but it's pretty uncommon. When we do see cord abnormalities in HIV patients, it's usually either vacuolar myelopathy, which is an effect of HIV infection itself, and if you see anything at all in the cord, you see T2 hyperintensity and atrophy. But most of the time, the cord looks relatively normal, and this is more of an autopsy diagnosis. What we used to see pretty frequently, especially at places like San Francisco General, was so-called CMV radiculomyelitis. And these are patients who often have CMV involving the retina, involving their gastrointestinal tract. They may have other lesions of the central nervous system or peripheral nervous system. And when we see this, what we typically see is linear enhancement over the conus and the cauda. And here's just an example that I took from the literature of a patient who had polyradicular symptoms as well as myelopathic symptoms. And you can see this diffuse enhancement over the conus that extended down into the cauda equina, and on the axial images we have enhancement of the roots of the cauda equina in an HIV-positive patient. Now, vascular lesions, again, this could be a whole lecture topic instead of just a quick mention in patients who are myelopathic. There are lots of different vascular abnormalities that can affect the spinal cord and cause a patient to present with myelopathy. Some of them are more common than others, and so I want to talk for a minute about some of the more common ones that you'll see. Dural AV fistulas occur within the dura covering a spinal nerve root. They may have one or more than one feeder from a dural branch of the radiculomedullary artery. Because they drain to the perimedullary venous system, they cause venous hypertension. And what does that do? That results in a subacute syndrome of progressive paraparesis and sphincter dysfunction that is most commonly seen in older males. But it can present as early as the teenage years, it can present in females. So dural AV fistula is something that you always want to have on the top of your brain in the appropriate clinical setting. And here's a really classic example. It's not always going to be this easy. This is an older gentleman with paraparesis, a T6 sensory level, and loss of bowel and bladder control. By the time he presented, he was obviously very far advanced. And what do we see? Sagittal T2 weighted image. The spinal cord is diffusely hyperintense, and it looks like the cord is hairy. You've got all these little black dots all along the surface of the cord. What are those? Those are large dilated veins on the surface of the spinal cord. Here's the post-gadolinium image. Sometimes those vessels enhance a little bit, but much of the time they don't enhance very much. So the sagittal T2 weighted image is your most helpful image in terms of thinking about the diagnosis of dural fistula. Here's a really nice example. We've never gotten it this good again. This case is from a couple of years ago, but we do try in these patients with dural fistula. This is a subtraction, thin slab, maximum intensity projection from a GAD MRA. Here's the aorta, here's the feeding vessel, here's the fistula, and here are the dilated veins going up and down the spinal cord. And here's just an example taken from the neuroangiogram that Dr. Marks or Dr. Doe did, where they injected the T8 level. Here's the fistula, and here are those big dilated draining veins extending up and down the spinal cord. This patient had a dural fistula at the T8 level, and he was treated and he improved somewhat, but he didn't regain a lot of neurological function. AVMs, if you're on the CyberKnife service, you're certainly going to see some of these patients. Most of these patients, unlike the dural fistula patients, these are young patients. They most commonly present with hemorrhage and the acute onset of neurological deficits, but they may present more gradually. And here's just an example of a patient on a sagittal and axial T2 weighted image with multiple enlarged flow voids. You can see how the cord is expanded. The flow voids are within the cord itself. Here are some examples from the spinal angiogram showing this big tangle of vessels within the cord and these big draining dilated veins. And this is a young man who had a fairly typical cervical AVM. Cord infarcts, again, maybe more the province of neurology than neurosurgery, but these are patients who often have severe atherosclerosis or aortic dissections. There are a lot of other causes of cord infarct, but these patients typically present with the acute rapid loss of neurofunction, and MR is mostly useful to exclude other causes of non-traumatic myelopathy. Because when a patient has a cord infarct, other than supporting them, there's often not a whole lot you can do. And here are 3 different patients with cord infarcts. This gentleman had had AAA surgery. You can see that his conus is markedly hyperintense. The central gray is very abnormal. And he was about a week out from surgery. And you can see how his gray matter is enhancing postgadolinium in this now subacute cord infarct. Here's another patient with a cervical cord infarct, relatively subacute. You can see how it's involving the anterior more than the posterior aspect of the cord, and again, that enhancement within the central gray matter. Here was a more acute patient, sagittal T2 weighted image with cervical cord T2 hyperintensity, and this is not a very pretty diffusion weighted image, but we can do diffusion weighted imaging of the cord, and you can see how that infarct is hyperintense on the diffusion weighted imaging. Okay, we're almost there. Just a couple more comments. Syringohydromyelia, another cause potentially of myelopathy, cavitation within the spinal cord, or just a dilated central canal. Symptoms, you know about this, so I don't want to go into it, but one thing you may not be familiar with is the concept or the phenomenon of pre-syrinx. By this, we're referring to potentially reversible cord edema or cord T2 high signal, which is caused by obstruction to CSF pathways. And the good news is that gives the neurosurgeon the opportunity to intervene and potentially reverse the process. So here's just a classic PD service example of syringohydromyelia. We've got a little kid with a severe Chiari-1 malformation. The tonsils are totally plugging up the foramen magnum, and you see this multi-level, non-communicating cervicothoracic syrinx. What about this patient? This is a young woman with subarachnoid hemorrhage who had a trapped fourth ventricle and new myelopathic symptoms, and she was brought down to the MR scanner. And here you see her big fourth ventricle. You see how her brainstem is being compressed. Her tonsils are plugging up the foramen magnum. And we've got this expansion of the cervical cord with T2 hyperintensity. What's going on? Does she have a cord infarct? What's the problem here? No, this woman has a severe pre-syrinx condition. And when the neurosurgeon went in and placed an EVD and decompressed the ventricles, you can see that the fourth has now risen up, the foramen magnum is normal, and this patient's cord edema has completely resolved over the course of a couple of days. And those arrows are just indicating some artifact that was spreading across the image. I couldn't get rid of them. Okay, so why are these flow pathways so important? Well, they're so important because when they get gummed up, patients have problems. And here was a case of a 52-year-old doctor who was a marathon runner who had some new gait difficulty and sensory deficits in his feet. And his history was notable only for remote spinal anesthesia. And I don't even remember what procedure he had had that had required spinal anesthesia. So he had an MR scan that showed no Chiari, no tumor, but this is what we saw. Sagittal T2, he's got some focal areas of syrinx formation, but he also has this very extensive area of cord abnormality that hasn't yet developed into a frank syrinx. This is pre-syrinx. When you look at his thoracic cord, again, he's got areas of syrinx formation, hydromyelia, but he also has areas that are just T2 hyperintense that are not frankly cavitated. So we suggested a CT myelogram in order to see what was going on with this patient's subarachnoid space. When I actually injected the guy under fluoro, you could see a block to contrast that after you tipped him for a while, eventually relieved and the contrast passed through. When we look at the sagittal and axial images from the CT myelogram, you get the sense, although I agree it's very subtle, that there are all these little lines within the subarachnoid space that were partitioning it into multiple non-communicating areas. So when the patient eventually went to the OR for exploration of his subarachnoid space, he had multiple adhesions, presumably related to that remote spinal anesthesia. And when those adhesions were lysed, He had improved CSF flow and improvement in his symptoms. So it is important to think about processes of the subarachnoid space because you may be able to go in there and do something. You can't always. Okay, we're done. 2 quiz cases. This is your opportunity to shine, all right? Quiz case number 1. This is a middle-aged woman with paresthesias in her hands and feet, as well as problems with touch, position, and vibration sense. She's not weak. Sagittal T2 weighted image. We've got this fairly extensive abnormality involving the posterior aspect of the cervical spinal cord. Axial T2 weighted images. We've got abnormal T2 hyperintensity, which is confined to the posterior aspect of the cord. Thoughts? Come on. I'm going to have to call on Dr. Lane, who's going to just nail it. Okay, so something inflammatory. Syphilis, all right, that's a good thought. ADEM, you know, it's long segment, but ADEM to be so confined posteriorly would be a little bit weird, but I would agree. Okay, so ADEM, a viral myelitis, syphilitic myelitis. What did I hear? Okay, Dr. Lane took pity on you. Okay, so we've got this hyperintensity in the posterior columns, and this is an example of subacute combined degeneration secondary to B12 deficiency. And it turned out that this patient had atrophic gastritis and pernicious anemia. Again, maybe more the province of neurology than neurosurgery, but if you do see this appearance, again, you know, out there in the community, once you grow up and go into practice, you know, maybe your radiologist isn't going to know what's going on, and you're going to say, Mrs. Jones, I'm going to check your B12. Okay, next case. This is a 44-year-old woman with progressive myelopathy. Sagittal T1, sagittal T2, axial T2. The bony spinal column doesn't look too bad, although the vertebrae look a little funny. Why do they have this little sort of like upbending of the, you know, inferior margin of the vertebra? And then she's got this thick, dark abnormality posteriorly and anteriorly, anterior and posterior to the spinal cord. Her cord is obviously squished and hyperintense. And when we look at the axial, she's got this thick thickening of the posterior longitudinal ligament as well as the ligament flava. So you might say, maybe this woman has what? Maybe she's got OPLL. But this doesn't really look exactly like the OPLL that I showed you, right? It's awfully multi-level. You know, even with OPLL, this would be pretty extensive. Also, it's sort of more lobulated. It's not like a thick bar, all right? So in fact, these ligaments are markedly thickened, but they're not ossified. Okay, so I'm throwing out OPLL. So what else are we going to come up with? What? Okay, so lipomatosis, except it's not fat. But that's a good thought. You certainly, absolutely, fat in the epidural space can cause severe cord compression and myelopathy. So you need to think about some other sort of deposition or infiltrative process. So maybe it's weird amyloidosis. Okay, that would be a potential thought. What else could maybe do this?
Rheumatoid arthritis.
Okay, so rheumatoid arthritis with ligamentous involvement. You might expect to see a little more whittling of the dens, but you could actually wonder if her C1-2 interval was a little bit widened. Okay, so we've got all this thickening, but we also do have this little bit of funkiness of the vertebral bodies.
Spondy.
All right, so differential, OPLL, CPPD, amyloid, mucopolysaccharidosis, deposition, right? Sarcoidosis maybe with deposition of non-caseating granulomas. Langerhans cell histiocytosis. I've seen this cause marked dural thickening, although I've never seen it cause an appearance like this. Some funky neoplasm, it really doesn't look neoplastic. And this patient actually turned out to have mucopolysaccharidosis. It's not the point that that's the diagnosis. The point is just to think about the differential, and that was just for fun. Okay, so thank you for your attention. In summary, I hope that was helpful, and I hope that gives you renewed interest for analyzing all those scans in your myelopathic patients. Thank you.
The preceding program is copyrighted by Stanford University. Please visit us at stanford.edu.